I would call the chairpersons Dr. Ramkumar, Dr. Pichumani and Dr. Dhanamitran.
At the outset, I would like to thank GVK sir and the scientific committee for having given me an opportunity to be in front of you. And there's a slight modification. We are going to have a first speaker, Dr. Shruthi Chandrasekar, who requires no introduction in this crowd because she's been giving a lot of lectures and an emerging endocrinologist. And she's quite interested in transgender endocrinology. Transgender, she treats a lot. She has got a bunch of patients. And she's also interested in transplant diabetes, post-transplant diabetes care. And she is going to deliver a talk on choices DPP4, evidence to date. Welcome, Shruthi.
Thank you, Dr. Pichumani. It was a kind introduction. Thank you. So what I'm going to be doing for the next 15 minutes or 10 minutes is a timer. So 10 minutes or so is the talk on the evidence to date on DPP4 inhibitors, specifically focusing on linagliptin. So what I will not be doing is comparing different gliptins or DPP4 to other class of agents. So this is with introduction. I'm going to give you the overview of different agents that have come over the past from 1950s to sulfonylurea available in 1990. We recently celebrated 20 years of sulfonylurea, and then with DPP4 now we know that we have data for the past 10 years, right, with sitagliptin being first. So we have enough data with DPP4 inhibitors. So the question always comes when I practice, what next after metformin, right? To me, every single drug, including sulfonylurea, TZDs, DPP4, GLP-1 receptors, SGLT2 inhibitors, and basal insulin have a role of what comes next, right? But what I'm going to be specifically talking for the next 9 minutes is giving you some sort of fascinating evidence with linagliptin as a molecule, right? What are the newer evidence that has come out with linagliptin, which I sort of learned while I was preparing for this talk. I should really thank Dr. GVK for giving me this opportunity to sort of learn while I was preparing for this talk. So if you also have to go by the recent ADA ESD guidelines, it is a very nice guidelines. You would have all seen this, where we have a patient-centric management, whether you have a heart failure predomination or a CKD or taking cost into consideration of your patient. So you can actually choose the drug depending on your patient's condition, right? What I think should also be included in the algorithm is liver disease. We had an excellent presentation of NASH and non-alcoholic fatty liver disease. I think we have seen a whole lot, in our liver institute, we see a whole lot of patients with NAFLD and diabetes. So I think we should also have an algorithm specific to patients who have liver disease, right? So that is not there, but apart from there, this is a very nice patient-centric algorithm that we can actually follow in our clinic. So in spite of all these things, we still have numerous challenges when we have to get the HbA1c under control. It could be age, compliance, the sustainability of the drug, comorbidities, hypoglycemia, weight. You can go with all these things could be the reason why we are not able to get the HbA1c under control. So what we need is a glucose lowering agent that has enough data for good glycemic control, because that is exactly why we use these agents. Weight neutral, low risk of hypoglycemia, of course no dose adjustment required in conditions of renal disease, liver disease, even we use it in the post-transplant setting, so that the safety of that molecule is very important to us, cardiovascular safety and renal safety. So with this, we all know we had a very nice talk by DPP4 inhibitor by Dr. Anand sir in the morning session. So we all know how DPP4 inhibitors work, and I still am having very less time to present my data. I'm going to skip these slides here. So the most important point, the 10 points about incretin is they are insulin secretion enhancers to nutrients, right? So it is an insulin secretagogue but works in a different mechanism through incretin pathway, unlike sulfonylurea, which acts in the direct potassium channel in your pancreas. It's once daily oral preparation, low risk of hypoglycemia. We've always talked about weight gain and hypoglycemia, and I'm sure majority of us know this point. We have data for preservation of beta cell mass. It complements metformin and SGLT2, which is what Krishna is going to be talking on, how you can use this molecule as a co-molecule, combining with SGLT2 in your practice. Offers pleiotropic effect, not that much as an SGLT2, but we do have some data with blood pressure control, especially with sitagliptin. And some of these drugs in trials have actually even shown a subtle weight loss, even though we call it generalized as weight neutral. Safety in elderly, we have emerging studies coming out in patients with cognitive functions, emerging cardiac and renal data, which I'll quickly run through. And overall, we all know for the past 10 years, we have been using DPP-4. It's overall a very safe molecule to start with. So when we were actually, this is exactly what I told you. So when we were in a forum where they were actually comparing this to actually this bike which was introduced a few years back with a tagline of just, set and go. That's exactly what we have been doing with DPP-4. You just start it, we know it works, we know the durability, we know the overall safety profile, so it's probably would actually suit this jet, set, go tagline, which was actually sort of introduced when this Honda bike came into the market. And with linagliptin, what we know is a sustained 24-hour true control, true inhibition of DPP-4 enzyme. And with Asians especially, not just Lina, we have data with other gliptins as well, including sitagliptin, showing that it has a higher efficacy in Asian population when compared to Caucasians, especially whites. And from the RCTs that we know, when you compare major DPP-4 inhibitors, they all have comparable efficacy. So about 0.8 to 0.9% HbA1c reduction. And if you have a patient who have a higher HbA1c to begin with, you're going to have a much pronounced effect like any other molecule that we know in diabetes practice, right? So this is just comparing all DPP-4 across, and whether you use it as a monotherapy or as a combination of sulfonylurea or even combining with TZDs. If you're using TZDs in your practice, which I do, even if you compare it with, combine it with TZDs, you do have a good HbA1c reduction, tolerability. There might be a subtle weight gain when you combine it with TZDs, but it's sort of not very much when you use only TZDs alone. So we have data with basal, bolus insulin, and also data with sulfonylurea as well. So overall, it has a good efficacy, and this is all we know. We know it is weight neutral. We know DPP-4 as a class has no risk of hypoglycemia or very minimal risk of hypoglycemia, right? So what are the newer stuff that are coming out, especially with what I started my presentation on, is we have enough data with fatty liver, especially in the animal model, and also in humans, which is going to be presented soon, is it alleviates the fatty liver. We have seen improvement in enzymes. We are safely using it in post-transplant setting, especially not immediately after transplant, couple of weeks after transplant when we have to sort of reduce the bolus insulin. DPP-4 is something that we would start, especially linagliptin, because we have enough data as far as the fatty liver is concerned. And what about elderly, right? So over 70 years. I mean, can I start it? Yes, you have data not just with Lina, but all the other gliptins saying that it's very, very safe in elderly population, because we know elderly population have a high risk of falls, and diabetes itself is a risk factor for osteoporosis. A lot of women do, or even men, come to us with hip fractures, with very subtle fragility fractures. So it is important to prevent hypoglycemia, and we have enough data with elderly population saying these drugs work well. And we also have a cognitive study, which is actually will be soon published, looking into the cognitive functions, because cognitive disease in diabetes, which is also called as type 3 diabetes, or Alzheimer's itself is considered to be a type 3 diabetes because of brain insulin resistance. We have data not just with Lina, but also with Sita and other gliptins saying that it has or offers some cognitive benefits. And about, these are all very small studies which I sort of learned while I was preparing this talk. We had the RELEASE trial here, which showed it decreases aortic pressures in early stage of diabetes, which probably could offer cardiovascular benefits if you actually start these agents early on in the treatment of diabetes. And this is an effort study. These are all very small studies. If you look at the number, it's only 16, 16 to 40. Very small studies done for 3 to 6 months. Again, this is only for 3 months, which showed that it had better vascular protection in patients with diabetes by measuring the surrogate markers for vascular disease. And this is again looking at specifically at the vascular functions with linagliptin. What it concluded was linagliptin tends to improve the endothelial and neurovascular microvascular functions, and it showed a decrease in the interferon alpha and all the inflammatory markers, which we think could be a cardiovascular risk factor in patients with type 2 diabetes. So this is again a very nice study. I know a lot of times we don't talk about it. It's a very small study, use of linagliptin in the inpatient setting. along with basal insulin. So this is something we know we've been using in our practice as well, even though the ADA recommends all inpatient management should be done with insulin, because insulin is the standard of care in the inpatient management. But we have a very small study saying that patients can be on linagliptin with the basal insulin if they are non-critically ill, I'll put it again, non-critically ill with mild to moderate hyperglycemia in the hospital setting, who were treated with oral medications at home, because we know this doesn't require any renal or liver clearance, right? So these are some of the newer studies that are out with linagliptin. Are all DPP-4 inhibitors same? Well, the similarities are efficacy, weight neutral, hypoglycemia, well tolerated, and there are differences with cardiac safety, heart failure, and kidney dosing. What we know with DPP-4, especially linagliptin, is there is no dose requirement, adjustment required, but other gliptins you have to adjust according to the renal function, not because they are renal toxic, but just because that dose is enough for the efficacy of the glycemia control. So that is one important take-home message. It works across different patients with chronic kidney disease, even in the setting of transplant. We use it in renal and liver transplant setting as well. And this is just a CVOT trials, which Dr. Anand Moses already alluded to in the morning. The Carmelina was different because it also included the 3P MACE, and secondary endpoint, it also included the composite kidney endpoint. And these were the patients who were actually enrolled in Carmelina trial. And I'm going to just come to this because I have very limited time. I have about a minute. So this is just to show that DPP-4 inhibitors are very, very, very neutral as far as the CV safety. So they are very, that's what the FDA wants it, and it is a very cardiac safe medication. As far as the heart failure, Dr. Anand also said there is a black box warning for heart failure with these drugs. That might change, because with Carmelina, we had a non-significant, it was statistically non-significant, but a 10% reduction in heart failure with linagliptin. So that labeling will change in the next year. So there was no increased heart failure in any of these subgroups. Even in patients who had heart failure to begin with, there were no increased risk for heart failure who were enrolled in the trial. And there were also a long-term renal protection, which showed a reduction in urine albumin creatinine ratio, which was also shown in a very smaller trial called Marlena trial, which was new to me when I was preparing, with 360 odd patients, showing that there's a 20% reduction in an albumin creatinine ratio with DPP-4. This is with all DPP-4s, but this trial was specifically done with linagliptin. So this is my last slide, ladies and gentlemen. So it might be used for a broad range of type 2 diabetic patients. It's one dose, once daily, after food, independent of kidney functions, liver functions, cardiovascular safety, including heart failure that we dwelled in the morning. Age, I showed you enough data with the safety as far as the age is concerned, and also cognitive benefits in elderly. BMI, because it's weight neutral. Background type 2 therapy, it could be sulfonylurea, it could be TZDs, it could be basal insulin, it could be anything, the background type 2 diabetic therapy, or SGLT2, which Krishna is going to be talking about, or the disease duration, because the patients who were included in the Carmelina trial had duration of 8 to 10 years of diabetes. So it's better you start these drugs early, but you see the benefits at any stage of diabetes as well. And also with ethnicity, we do see greater efficacy in patients, especially the Asian patients. So with this, I thank Dr. G. Vijayakumar for giving me this opportunity to present this afternoon. Thank you.
Thank you, Shruthi, for your talk. And if she wants to leave early, if you have any doubts, you can just ask now.
Why DPP-4 inhibitors are very effective in Indians?
In Indians. So I think it's something to do with the pharmacogenomics, right? So we have pharmacogenomics, which we talked about in the last session. We do have, I don't know exactly what the genomic is. Even for metformin-induced gastric disturbance, we have a gene that is responsible for the specific nucleotide thing. So probably Asians have the susceptibility for these drugs to work better. So that would be my only explanation. I don't know if anybody else has any other thoughts about it. Krishna wants to answer that question.
So several hypotheses basically about this question. One is of course the pharmacogenomics. I'm not so sure, because we look at the Malaysian population, which has both Chinese and Indians. You'll see the only variation is the TCF7 and 4, where the response may actually be lower when you have a TCF7 and 4 variation. but three hypotheses for DPP4 stand out. One is beta cell dysfunction. The greater the beta cell dysfunction, the greater the benefit. So you'll find the greatest benefit is seen in East Asians, where the beta cell dysfunction is very high, as opposed to the Caucasians, where insulin resistance is predominant. Second is BMI. There seems to be an inflection point of BMI at which DPP4s work better. SGLT2 inhibitors work better at a BMI of greater than 30. DPP4s work better at a BMI less than 30. This is very interesting. Lastly, diet. In fact, two of the Indian trials that looked at DPP4s and the importance actually showed greater benefits in West Bengal and Kerala. And guess what is very common in both these populations? Fish. Similarly in Korea. So there are a bunch of other things, but these sort of seem to stand out as one of the reasons why Asians do much better. And interestingly, we are going to see some of this data from SGLT2 inhibitors as well. So some very interesting stuff, but great question, and thanks for allowing me to answer part
Sure,
of it.
thank you. I would have not answered it anyways.
Point from this, I think there are some soft data highlighting that the DPP4 activity is much more in some other populations. So it makes sense to interfere, whichever is the allowing the normal GLP level to function, if it's going to be prolonged.
Can I just respond? And that's a very interesting point, and it's actually the soluble DPP4. There are two kinds of DPP4. One is the membrane bound, and the other is the soluble bound. I think there seems to be a level different in the level of actions of soluble DPP4, which makes a whole bunch of things. But interestingly, remember that all of us link DPP4 inhibitors with GLP-1 action. Now, it's been well shown that less than 50% of DPP4 inhibitor action is mediated through GLP-1. So, 10 years after these molecules, we're learning a lot of things. Thank you, sir.
Can I ask you a question, sir?
No, sir, we talked about
Thank you.
Thank you, Dr. Vijay and organizers for giving me this opportunity, and I should appreciate the greatness of this conference. People are staying inside without a break. They're not going out, and it's very interesting. Give them a big hand, please. And audience, we should appreciate them also.